miniature radiation linear accelerator. Our patient would be on this table. The table would actually be lower and then would raise up. It would slide in, and we would align the area that we're treating under the gantry. This is the gantry, and the radiation beam would be coming from here. So this machine can actually rotate 360 degrees and deliver its radiation to the tumor at the same time. Some of the things, though, that you have to think about is that this patient is alive and they're moving, and I'm here planning on a very stationary object. So you got to keep it in the back of your mind that this is a moving target. The patient's not always going to be just holding completely still. They're going to be breathing. So their position needs to be such that if I do come in with these posterior beams, am I going to be exiting through their arms, or are they positioned in the simulation in such a way that I have more flexibility to how the treatment plan can be generated?
So the way we manage movement is we fabricate custom-built immobilization devices so that the patient can be still. Most adults and adolescents can be still, so we may make a mold or a cradle, sort of like a half body cast that someone can lay in that adapts to their crotch and the area under their arm and their shoulders so that they can be in a reproducible position. That question of how we balance the positive and the negative, really you're addressing something called the therapeutic ratio. We can actually cure all tumors with radiation if we give enough high dose of radiation. The problem is that would overlap with the toxicity curve and we would cause a lot of damage. So what can we do to really separate the therapeutic curve on one hand from the toxicity curve on the other hand so that they don't overlap and hence increase the therapeutic ratio? One of the things that we do nowadays is we use image guidance as a form of part of our treatment planning and delivery, where we actually can see where the tumor is when the patient is in the treatment position. And we can minimize our margin, meaning the area that we're going to treat with radiation, such that we minimize the dose, to normal tissue nearby. So image guidance, either with ultrasound or cone beam CT scanning or other techniques, may allow us to really increase the therapeutic ratio. We use linear accelerators, which have a range of energies with electrons, X-rays, also known as photons, and we use that for most of our patients. We have brachytherapy, where we deliver iodine-121 or palladium-103, different radioisotopes to patients. One of the other areas that's very exciting is giving iodine-121 and other radionuclide tracers for patients with certain tumors, such as thyroid malignancies. We also use radionuclide tracers to help image certain tumors and abnormalities via functional imaging. The PET scan, PET, or positron emission tomography imaging tool, is one type of functional imaging tool. Another one's called a SPECT scan, single photon emission tomography, for example. CT scans, MRI scans, ultrasounds are also very novel imaging tools that we use on a regular basis. One of the most exciting, going back to therapeutic radiation, one of the more exciting advances, at least for our program here in Oregon, is the use of intraoperative radiation therapy. And that means, just like it says, when the patient is in the operating room and the surgeon has removed all the tumor they can, we're able to move the normal structures out of the way. So if we're operating in the pelvis, we can move the bladder out of the way, the kidneys and the ureters out of the way, the different nerves, the different bowel, and just focus on the tumor and give a high dose, usually a week to a week and a half worth a dose of radiation in about 1 or 2 minutes via intraoperative radiation therapy to a part of the body. So we think that's a novel way to give a high dose of radiation and minimize dose to normal tissue, and hence increase the therapeutic ratio. So intraoperative radiation therapy is a new part of the surgeon's toolbox. Future technology is going to really exploit image guidance and adaptive planning. And what I mean by adaptive planning, normally we start with a customized plan and we commit to that throughout the course of treatment. we need to be able to be nimbler to assess the tumor, the way it's responding or not responding, as well as the normal tissue. How is it responding or not responding? And be prepared to alter our plan. Just like when we come to work every day, we have alternate ways to get to work depending on the traffic flow, the time of day. With radiation, we oftentimes deliver that in a set pattern that we stick with, and we may not be able to assess the biology during treatment and maybe change the pattern, change the temporal relationship on how we deliver radiation therapy. So adaptive planning, changing course in the middle of a plan, may be useful for some patients. So that leads into my ideal way to deliver radiation therapy. We want to be able to continuously be able to assess the tumor, the way it's behaving, and such that we might decide to give a large fraction of radiation Monday, perhaps 2 or 3 smaller doses on Wednesday, and no treatment on Tuesday. That would be a customized radiation approach for a given patient's tumor for a given time. So that would constantly involve imaging and getting feedback and reanalyzing, and I guess I would say iterative learning and iterative delivery.